Okay, today we are going to discuss diagnostic measures and data cleaning. Okay, for the second part, we are going to use Microsoft Excel to clean the data and to order them, to move on from data that are categorical, to classify them, to code them, from data that is continuous to data that is categorical. If we want to go from continuous to categorical, how to clean the empty cells, how to estimate them if we want to do that, and so on. For the first part, we will just review the association measures a little bit, then we are going to discuss diagnostic measures. Is there any question about the topics that were presented last week? Not last week, last session. Okay, then we can start. If you remember here, if we have something that is causing something, okay, we will happen to get association between them, okay? Yeah, Massa, do you have a question? Okay, so we have association between two things. So the first thing we think about is causality. If we know that one thing of those two happens before, okay? But to prove causality, we will need a lot of work and a lot of time, a lot of studies, and we need studies from different levels in the pyramid to prove this causality. We can't prove it from a case control study. We need a randomized control trial, because for a randomized control trial, we will be quite sure that our intervention is the cause for the outcome. For retrocausality, after we put our assumptions, we found out no, it's not this way, it's the other way around. The outcome is causing the reason in our reasoning. Okay, confounding, there is something else that I don't know, or actually I didn't know when I collected the data, and this thing is affecting the cause and the outcome, okay? For example, age is affecting diabetes and mortality. Diabetes won't cause mortality unless diabetes affects those with old ages, okay? For example, this is an example. Of course, there are a lot of other examples for confounding, such as smoking. For example, there was a study that drinking coffee causes pancreatic cancer, but actually it wasn't drinking coffee. Those who drink coffee usually smoke with the coffee, so smoking causes pancreatic cancer, not the coffee itself. So this is another example. Random error is the probability of chance, and we always talk about the p-value, the probability of chance, and when it happens, this is this is what happens, okay? This is the cause for the association we are getting. It's just by chance. For systematic error, you remember the examples from the last session. There is something else that is like a device, like any other error that I can calculate, okay? For random error, I can't calculate it because it's a chance, it's an error. But for systematic error, it's a bias that I know, okay? That device is just reducing CRB by 0.1, for example. So if I add 0.1 to that device, to the results in that device, the results will be correct. Okay, so I can correct it, then it is a systematic error. It happens every time. Okay, for odds ratio and relative risk, odds ratio is used in case control studies because we do not have the whole population. We have just that probability, and that probability is called odds. Okay, I can't have the total in my formula. For the relative risk, it is the whole population or a cohort that I'm gathering everything. So I can use the total amount to take the risk. For attributable risk and absolute risk reduction, we put a probability minus another probability. And if the outcome is positive, then this is absolute risk reduction. My intervention saves people. If the exposure is harmful, then it is attributable risk, and the outcome is negative. Okay, from attributable risk, we will take the number needed to harm. 50 people need to be alcoholic in order to get one to have some kind of cancers, for example. For the number needed to treat, I treat 3 people with aspirin, for example, so I save one from a heart attack or something like this. Okay, so this is the easiest way to manipulate numbers for interventional studies. So what about diagnostic measures? Is there any question about association measures? Okay, I don't feel everything is okay, but I'll move on. If there is anything, just please interrupt me. Okay, where to go now? This. Okay, now we have a diagnostic test or a criteria or anything that helps me to diagnose people with disease, without disease, or to rule out disease, to rule in disease, okay? And we have the disease that is happening in here. Okay, so I have a 2x2 table like every other categorical data. Why categorical data? Because I don't have those who have just a little bit of diabetes mellitus. They either have the disease or they do not have the disease, okay? But there are those errors. And if you remember, those errors happen in 2 ways. The first way, first let's talk about the correct decisions. When people have the disease and I say they have the disease, then it is true positive. What is the opposite of that? False positive. They do not have the disease, but I'm saying those people have the disease. So this is type 1 or type 2 error?
Type 1.
Type 1. Okay. If they have the disease, but I say they do not have the disease, false negative, then this is type 2 error. And here we have true negative, those who do not have the disease, and I say that they do not have the disease. And here we have just augmenting them. Yeah. Okay. What is sensitivity? We need to remember that sensitivity and specificity are taken from columns, okay? But remember that they are taken from columns when the test is on the left side and the condition is up there. Okay, so when we have that normal or standard 2x2 table, sensitivity and specificity are from the columns. What is the logic in them? Okay, when I say there is something that is sensitive, okay, sensitive, so it captures everything that might be that might carry the probability of my inclusion criteria. Okay, then, and it comes from a column. It shouldn't come from those without the disease, because I want those with the disease, so I take it from that column, the condition positive. What is the formula for sensitivity? It's actually true positive on the column. So those who are truly positive on all those people who have the disease. Okay, how to increase sensitivity? I increase sensitivity by reducing false negative. Okay, false negative, those who those who I say do not have the disease while they actually have the disease shouldn't be there in order to have a higher sensitivity. Okay, what about specificity? Specificity is actually saying that I need to rule out, I need to say that those without the disease are 100% without the disease. Okay, so specificity comes from the condition negative. Okay, and how is it calculated? Those who are truly negative on those who are truly negative and or false positive. Okay, so what we are saying is I need those who are truly healthy, and I say they are truly healthy on everybody who is actually healthy and I don't know about them. So in order to increase specificity, what should I reduce? I should reduce that portion of people who actually have the disease, sorry, doesn't have the disease, but I say they have the disease. Okay, so when we say that sensitivity is related to false negative and specificity is related to false positive, okay, then when will we use sensitivity and when will we use specificity? Okay, I will need sensitivity to take everybody. For example, if I have COVID-19 and the disease is truly contagious, I need everybody. I don't want to lose anybody that goes undiagnosed while he has the disease. Okay, when I'm saying that, I'm saying I don't need anybody to be false negative. I need everybody in. I don't care about those who are false positive. Okay, give me 100 people who are false positive, who I consider positive while they are not, but what I care about is those who are false negative, those who are going around the streets while they are like spreading the infection. Okay. When I have, for example, an intervention that is truly difficult or that affect the quality of life, like chemotherapy, for example, I'm not giving chemotherapy to anybody unless I'm 100% sure that he deserves to be treated with this, not deserves, I mean, but he needs to be treated with this treatment, with this harsh treatment. Okay, so I'm not giving the drug unless I'm 100% sure he has a disease. Then I don't need anybody who is false positive. Remember that we didn't care about false positive in sensitivity. I need everybody to come because I will just put them in the hospital. But here, I don't need anybody to take chemotherapy while he doesn't have the disease. Okay, so I don't need those with false positive, but I don't care at all about those with false negative. Yeah, let that person go in the street because chemotherapy will be harmful in the other way. Okay, but why can't I get a high specificity and a high sensitivity at the same time? We will see that in the next slide. But there are two other measures. They are not that common, but remember that post-predictive value, the predictability of positive value. Okay, when I have a positive value, what is the predictability of this? Okay, then I need to take a row. And what is the row? The row is actually all those with test positive. Okay, I need all those with test positive, and I need to divide on them those who are truly positive. Okay, truly positive on everybody who is positive. Okay, when it is high, then I know that my positive value means a lot. Negative predictive value is the other way around. I have a negative test, okay, and the negative test, how much can I trust this negative test? So it is true negative on everybody who is negative, okay. If the negative predictive value is not that high, then okay, and I have a negative test, you will tell me, okay, you just have 80% probability of having this negative test true, and in 20% you will be actually diseased or having the illness. So, is there any question about this slide? Okay. Why we can't get any high specificity and high sensitivity at the same time that easily? Actually, because those with the disease and those without the disease are continuous, okay? Those are two populations, and populations are not separated. I can't say you are 100% having that disease and you are 100% do not have that disease. So they are mixed actually, and those overlapping between them is the errors, are the errors. So here we have type 2 error and type 1 error, and yeah, of course, for some diseases they are truly they are truly far away from the normal distribution of the general population. So when I have the mean of the distribution of patients, and this mean is far away from the mean of people without the disease, then those overlapping will be less likely to happen. But when I have a disease that has the mean value of, in that test, I mean, really close to the mean of the truly negative or to the normal population, then I will have a lot of overlapping and a lot of false results. Okay, what can I do if I improve the device or I improve the criteria? I add more columns, more variables to the criteria in order to make it highly distinct or less variant. Okay, so I reduce the variance in each one of those columns. For example, if I have a criteria of two options or two groups, so I just have much variance between them. But when I have a lot of them and they are distinct from the normal population, I will have the variability between those two, the variability within those two distributions less, and that will give me a higher trust in my results. Okay, if you see here, we the last time when we talked about the null hypothesis and how to deal with the data there, we used that line. And you remember, we do not know that point in order to put the line here in the middle. What we do is actually putting the line here if we want to rule in or to get everybody who is truly positive, or to take the line here to to take the line here if we want everybody who is truly negative. Okay, and those two distributions sometimes are in the other way. Okay, so here we have here individuals who do not have the disease. Okay, so here we have the negative distribution and here we have the positive distribution. Okay, when I move the line to here, what am I increasing, the sensitivity or the specificity?
Sensitivity.
sensitivity. But why?
Because I'm taking the true positive. I'm taking everybody in.
Yeah,
And
I'm
also,
increasing true positive, but remember that we linked it here to false negative.
And decreasing false negatives.
Exactly. So false negatives just relate the line to the errors because those are huge distributions, and we are talking about those. Actually, those are not that large in the real situation. They are really small, so they truly affect. And why do they truly affect? Because I have true positive here and true positive here. I'm just playing with the false negative. Okay, so increasing true positive doesn't mean anything to sensitivity. What means is the false negative. Okay, so when I'm taking this line here, I'm reducing false negative, so I'm increasing sensitivity. Okay, when I'm taking the line here, I'm decreasing false positive. Okay, remember false positives, those who are diseased, but I don't want to give them a chemotherapy. Okay, so when I'm reducing those, I'm increasing the sensitivity, the specificity, and this is okay. Here we have them in a different distribution. They are not similar to the last slide. Okay, I will. Okay. This is not effective, but yeah, please tell me what is B, A, and C? Because we need to care about the lines and the distributions and where are they located. Okay, here we have the true positive here and the true negative here. Okay, so yeah, please tell me what is A.
A is about true positive, so it's about sensitivity. I mean C. No, A. Come on, A.
Yeah, A. What is
Okay.
A?
I don't know. Sensitivity.
Yeah, remember that I don't have any. What is the wrong number in here?
Specificity?
Sorry. Yeah, sorry, I didn't hear anything. What is the false probability I'm reducing in here?
false positive.
I'm reducing false positive. Is that true?
No.
Actually, here we have on the right the true positive and on the left true negative. So where is the false positive and where is the false negative? Yeah, I see that you do not know them unless they are written.
Oh my god. Give us
False
time.
negative on the left.
So just please tell me what is this? What is this? Don't draw in here. Okay, what is this? What is the probability in here? False positive or false negative?
False.
Positive.
False positive.
Was positive.
False positive. Yeah, take your time. Take your time and give me any other option.
Can I change my mind?
False
and
negative.
say false negative?
Okay, this is the usual way. We were training on this distribution from the very beginning. Okay, right? Right or not? Usually we have those who are different on the right, but I just mixed them in here. But here we are back to the normal. Okay, so here Okay, if I'm standing here, okay, what is this probability? It's false negative. Why? Because I'm standing in the true negative, in the negative distribution, while I belong to the true positive. Okay, I am true positive, but I'm standing in the false position, right?
Yes.
Okay, then I am false negative, right? And here I am false positive.
Yes.
Okay, then when I take the line into here, what do I do? What do I do?
To where?
Yeah, A. I mean in A.
Since it's false negative, then it's
False
sensitivity.
positive. False
Okay.
positive.
Okay. And for the other one, for the C.
I have more true negative, so specificity,
Okay.
right?
Okay. So there is a lot going on the chat. Please, Sarah, can you tell us if there are just answers or?
They are answering.
Okay, answering and maybe
Yeah.
false or right.
Right. Hello?
Okay, perfect. Okay, what do we have in here? Okay, if you remember, we have a specificity and sensitivity. And when I move, when I move the line to here, that's right, I'm increasing the specificity. But what am I decreasing? I'm decreasing
sensitivity.
Okay, so what is the solution in here? Having the two distribution far away from each other or reducing the errors. So I know that when I increase specificity, I decrease sensitivity. Okay, if I need to plot them, okay, can you tell me why sensitivity and specificity are increasing to the right? Why are they increasing together?
Small overlap between two curves.
Actually, the scale here
They're not increasing because
is inversed.
the numbering of the specificity is reversed.
Yeah, exactly. But usually, when you see that, it should be when sensitivity goes up here, we need the specificity to go down, like from here to here. But here they just inversed, conversed that scale. Okay.
Why did they do that? What is the benefit of?
Okay. Because the normal chart you need to see is that one. We need the line to look like this, okay? But we have two ways, either like taking the scale and the other way around, or putting a number that is 1 minus specificity. And what is the number 1 minus specificity?
Sensitive. Oh, no,
Oh, it's that error. Hold on.
What is it?
Is it false negative?
Is it the power of the shebli?
The false positive?
False.
Not the power, because we are not talking about those things here in diagnostic criteria.
No, power one minus factor.
Okay. Yeah. And actually in here, sensitivity
associated
resembles power in interventional studies. Okay. So 1 minus specificity means actually the probability of the false negative. Okay. Sorry, the false positive. Okay. So what is it?
Type 1 error.
Type 1 error.
Alpha.
Okay, let's just go to specificity. Okay, true negative,
Yeah.
false positive, and true negative. 1 minus this means we
This
have
was
false
positive.
positive,
I told you.
the probability of false positive. Okay, just put 1 minus specificity, 1 minus those. It means false positive. The probability of false positive.
Can you please use the red marker?
Why? Just 1 minus this.
The pointer is too small, I guess that's why she's asking.
Okay. I'll take that spotlight.
Where
Okay.
you
Now you can see it.
You have to move the pointer slower, just that. بس أحسن.
Okay, I will do. Okay, so let's say I'm taking just for my consideration. I want to make the chart look like this. So I will take, instead of reversing the scale, I will take 1 minus specificity, which means probability of false positive. And here we have the probability of true positive. So in that graph, you might see sensitivity and 1 minus specificity, and on the other, similar graphs, you will have a true positive probability and false positive probability. Okay, just not to confuse you. Those two graphs, what do I use them for? Just imagine if I'm taking the sensitivity and the specificity, putting them together into like this. Okay, do I need that number? That number has 1 and 1. Okay, do I need that number here?
I guess I need the middle number, like to get as high of both of them together, like to get
exactly
good sensitivity and good specificity together. So I won't take the numbers on the sides.
exactly, and I don't know why I can't just move back to draw. Yeah, draw. I still can't draw.
I can draw it for you. You want to draw here?
Yes. Okay. Why? But why not here and why not here? Here I have 0 sensitivity, and here I have 0 specificity. Okay, remember that in here, if I have 1, it means 1 minus 1. Okay, then it means like the specificity is 0 in order to make the scale 1. Okay, so I don't need 1. I actually need the 0 in here and the 1 in here. And how to get that? It's actually the closest point to that point. Okay, so the closest point to this point is something here on the angel on that side. Okay, what does that give me? That gives me the highest possible sensitivity and the lowest possible 1 minus specificity, which means the highest possible specificity. Okay, so I usually use this graph, the area under the curve, and the CUR graph, just to capture the best cutoff to choose my sensitivity, the best cutoff for my sensitivity and specificity. Okay,
We're out of time.
to keep your questions, and we will meet in 10 minutes. Okay, I'm sorry for that.
Okay.
Okay, We will continue from here.
Sure.
Hey, so some people on the WhatsApp the chat group, they're asking for a password or ID, and I'm not sure.
Okay,
I'm not the
okay.
host anymore.
I can send it again. I can.
Okay.
Thank you. Right. Copy. Thank you so much, Lina. Okay. We are here. Okay, can you see my screen? Perfect.
Yeah.
Yes, we can.
Okay, perfect. This is the ROC curve, and we agreed that we use it to define the best value for sensitivity and specificity. Why? Because in here, in the 0, I have the highest specificity possible, and here in the 1, I have the highest sensitivity possible. So the best point is here. Sometimes I care more about sensitivity, and I take this point. Sorry, when I care more about sensitivity, I take this point, although it is low in specificity, and when I care more about specificity, I take this point because although it is low in sensitivity, but I don't take this. Okay, why? Because the difference between this point and this point what is the difference between this point and this point? I have lower sensitivity for no gain in specificity. But from here to here, okay, I have lower sensitivity, but an increase from here to here in specificity, okay? So those points from here to here are all important, okay? Let's move on. How can we make this? Actually, this is one of the ideal curves we can see because it is truly close to here. Like I can say that the sensitivity, the specificity is 90% and the sensitivity is 90%, which is quite high. I might sometimes reach 99% in both of them, but what do I use the AUC? What does the AUC mean? It's the area under the curve. Do you agree with me? If this curve is higher and the area under the curve is higher, I have a better test? Or don't you agree with that? Thumbs, please.
I
No.
do.
Thumbs are better than the chat, okay?
Yes.
So somebody doesn't
I
know
don't
if he
agree.
agrees or not.
I don't agree.
Why? Okay, you don't agree. Okay, I need a test with high sensitivity. You give me a test with 100% sensitivity and it is 50% specificity. I tell you, give me a test that is high in specificity. You give me a test with 100% specificity and 20% sensitivity. I don't need those both. I tell you, I need a test that is high in sensitivity and specificity. You bring me an ROC curve, and it goes like this. From here to here, okay? I took the best point. The best point is here. I took it here, 70% specificity and 70% sensitivity. I ask you, don't you have any other test that is higher in sensitivity and specificity, both of them, you tell me, yeah, somebody else comes and tell me that I have that test, and that test is really higher in sensitivity and specificity because I have 90% and 90%. Somebody else came to me and told me, oh, I have that test, okay? It is 99 to 99. Do you agree this is better?
Sure.
Honestly, the more the tip of the curve is near 0 on the x-axis and near 1 to the y-axis, means that we have the higher specificity and higher sensitivity. And in this situation, the area under the curve will be near 1.
Exactly. Thank you so much, doctor. So yeah, this is the point, okay? The higher the curve is, the better my device is. So we get rid of those. Okay, here I don't have, here I have a test that makes no sense, okay? If I do it or I don't do it, it's not sensitive and not specific at all. But here, okay, it's good, and the area under the curve covers 65% of the area in the chart. Here I have a better one, and this one covers 90% of the area of the graph. And here you can see that the higher the AUC value, the better is the test quality, okay? So I don't compare two tests by their sensitivity alone or their specificity alone. I need to compare them with both of them, or by taking that number that represents both of them, which is the AUC. Okay. Undo, close. Okay, if you agree with me, this is the test on the left, this is the disease on the top. Please unmute your mics. And we have sensitivity, we agreed about it, we agreed about specificity, positive and negative predictive value. Now we have different terms, okay? What are those terms? Likelihood ratio, okay? If I come to you and I tell you you have that test and that test is really sensitive and you have a positive or a negative result, okay? It's still difficult to understand or to appreciate the probability in that number. So what I need to give you is a probability, okay? I tell you, you are 99% probable to have that disease, or you have the probability of 80% to be healthy, okay? Do you agree this probability or the risk, if you remember, the risk is better than odds ratio or anything else. The risk is, it's really easy. 20%. You have a probability of 20% of having that disease. After I do the test, I will give you a probability of 90%. Okay, so it changes after the test from before the test. Remember that sensitivity and specificity do not change. Okay, before the test, after the test, whatever. Okay, they do not change. But when I have a rare or common disease, positive predictive value and negative predictive value change. And it is truly difficult to explain it in here, but we need to move on to an easier measure. Okay, what is an easier measure to understand? Likelihood ratio. What is the likelihood ratio? Okay, let's talk about it like a probability without thinking, or just forget about sensitivity and specificity, okay? Likelihood ratio is a probability of having a test that is positive in a diseased person, okay? On the probability of having the disease positive in a non-diseased person, okay? What does it mean? If you have the disease, okay? If you have the disease, if you have the test positive You need to understand that, like the probability of those with the disease and the probability of those without the disease is high, then the sensitivity, I can understand it more. Okay, right? Let me say it in another way. Okay, what does that formula mean? Probability of positive in diseased on the probability of positive in not diseased. Okay, it's like the risk ratio, but for diagnostic studies. Okay, so let's think about the probability that the test is positive in a diseased person. Probability of the test is positive in a diseased person. It's A on A and C, which is sensitivity. We put sensitivity in here. Okay, on the probability of false positive, okay, of having the disease positive in a non-diseased person. B on B and D, okay, B on B and D. And what is it? B on B and D is equal to 1 minus specificity, okay, because specificity is D on B and D, okay. So I put that, okay, and this is the way to calculate it. But understand that positive in a diseased person on positive in a not diseased person. Okay, we move on. The likelihood ratio that is negative, okay. What is the likelihood ratio of a negative test? It is the probability of that disease being negative in a diseased person on the probability of that test is negative in a non-diseased person. Okay, it is exactly the same, just removing positive, putting negative. Okay, why? Because I use likelihood ratio that is positive in a positive test, and I use a likelihood ratio that is negative in a negative test. Okay, so when you have a result that is positive, I tell you the positive likelihood ratio. It makes no sense to give you the negative likelihood ratio. It is not relevant to your result. But when you have a negative result, I will tell you, okay, the probability of those who do not have the disease on, the probability of those who have false positive on, the probability of those who have a false negative on the probability of those who have a true negative. Okay, those who are negative and diseased on those who are negative and not diseased. Okay, negative and diseased, what does it mean? Negative on diseased, so it's D on D and B, then it is sorry, negative in a diseased. I'm truly sorry about this. Negative on a diseased, what does that mean? C on A and C, which is 1 minus sensitivity, on negative in a not diseased person, D on D and B, which is specificity. Okay, after we calculate them, we understood that we use the likelihood ratio positive for a positive result and likelihood ratio negative for a negative result. This is a repetition. Okay, I'm really sorry, this should be a minus. Okay, let's move on with the first one, a positive likelihood ratio. I told you about this formula to calculate it. Sensitivity on 1 minus specificity. Okay, and we say that it is calculated when the test is positive. Okay, so what is it used for? Okay, what do you think? What do you think that what do you think this number can say? Or how can we use it? when I have a test that is positive, will I be happy when the likelihood ratio is high or low? Do you think?
Well, low, because if it's high, high, because if it's low, we will have like positive when people are not sick, right?
Okay, just let me tell you that likelihood ratio that is positive is high when sensitivity is high, okay? Remember that specificity and sensitivity are related to each other. So I can just say likelihood ratio positive, I relate it to one of them, okay? Why? Because when last time, you remember in that formula, we had the same number, just up and down. But here, no, we have a number in here, and the specificity is related to it, okay? So if I relate a likelihood ratio to sensitivity, it is already linked to specificity. So likelihood ratio positive, and it is high, then I have a test that is sensitive, okay? I will be happy. Why? Because I will be sure, okay? I won't be happy because I'm having the disease, but I'll be happy because I'll be more sure, okay? It's more sensitive. It will give me a more important result. That test will give me a more important result when it is positive. What is likelihood ratio? Okay, do I need likelihood ratio? Sorry, what is the negative likelihood ratio? Do I need it to be high or low? Okay, remember that I just need to link it to one of those. Okay, so let's link it to. So, yeah, please, Rama, tell me.
It better be low because I don't want negative people testing positive.
Okay, but can you tell me about this in relation to the formula instead of the just the concept, the theoretical concept?
I'm afraid of getting lost.
Should it be high or low?
The lower the LR is, the better sensitivity and specificity I should have.
Exactly. So the lower the LR is, the highest the sensitivity I will have. Okay, so I will be more sure. Right?
Yes.
Remember that sensitivity and specificity, I can't have them both high. Okay, I will just link to one of them. Should I have a higher or a lower number for this 1 minus sensitivity? If I have a high number, then I have a low sensitivity. If I have a low number, it's a high sensitivity. Okay, I also need it to be high. Okay.
And I know which one is better. Is it a better sensitivity test or a better specificity test just by knowing the LR?
Just by knowing the LR, I don't think so. Actually, I didn't thought about this before, but yeah, actually, I don't think so.
Maybe
from LR
you
can't distribute the number to here and here. Okay.
Yes.
Just let me not answer this question because I'm not 100% sure, but logically, we don't need that information. Yeah, the information you are asking about, because we are calculating the likelihood ratio from those numbers. Okay.
And maybe it doesn't very much exist. Like there is no perfect sensitivity without specificity. Like any study will take just a reasonable value for both.
Exactly. So for likelihood ratio that is negative, I need the low number. Okay, we move on. I need you to answer this question. Please just
excuse me.
Sorry, Dr.
Excuse me, Dr. Ibrahim. I think it depends about how important the higher or the lower the likelihood ratio is, both positive and negative. I think it depends on the purpose. If the researcher is concerned about not missing a single case. So he will be happy if he has a higher positive likelihood.
Yeah. Yes, Doctor, you are 100% sure, but when a researcher is thinking about a test, he usually thinks about the AUC, the sensitivity, and the specificity. Why? Because those are the numbers that are constant, okay? But when we are talking about a patient, that patient will care about the likelihood ratio and the positive and the negative. Why? Because he has a result and he wants to know if that result is like confirming the disease or ruling out the disease. Okay, and just please let us answer or discuss that in more details just after this slide. Okay, because this slide is really important. I just want you to think about what is the best. If I think a person has an infection, okay, what is the best test to use out of those? And if that person, I don't think that person has a disease, what is the best test to take? Okay, just please send to the chat because it will be confusing if you are going to talk. Just send for positive 1, 2, or 3, or for negative 1, 2, or 3. Maybe I shouldn't. Yeah, but you can see it actually. Two for positive and 3 for negative, Rami. Okay. 3 negative. Okay, maybe we can continue. I don't think anybody answered both of them correctly. Okay. Let us say that I ordered the test and it is positive, okay? And I need to roll in, I want to roll in that infection, okay? What is the best test? It's actually the second one. Why? Because I need the likelihood ratio that is positive to be the maximum, okay? Because when I have the test that is positive, I need the sensitivity to be high, okay? Remember that likelihood ratio of positive is related to sensitivity. So the higher the sensitivity will be higher, okay? But when I have, remember that the positive point about sensitivity is when it is positive, okay? The other way around, if I have a negative test, okay, what should be the negative likelihood ratio?
The lowest?
The lowest, actually, yeah.
Yeah.
The lowest, the negative likelihood ratio is the best. Why? Because the lowest will be the higher.
Give me the higher sensitivity.
Okay, and the higher sensitivity will rule out the disease. Okay.
So I answered correctly. No one answered.
Actually, I don't. Yeah, yeah. I'm sorry for that. So those are the numbers we need to take. into consideration. Okay, remember that in this way we know that not both tests are the best for each side of the decision. Okay, sometimes I would prefer the CRB, and sometimes I would prefer the procalcitonin. Okay, and why? Because of likelihood ratio. Those can't be interpreted by sensitivity and specificity. Okay,
Ibrahim, how can you interpret these results by words?
yeah,
So
next slide.
Oh, okay, thank you.
Okay, you are welcome. Okay, so if you agree, we move on to the next slide. Actually, the first possible benefit of likelihood ratios are to choose the test. For the negative result, I will take the or to rule out infection, I'll take the lowest, and to rule in infection, I will take the highest. Okay. The second benefit out of those is the pre-test and post-test probability. What is the meaning of doing a test? Actually, I need to increase the probability. I'm thinking about a probability of 50%. This means nothing to the patient. I need to increase it or to decrease it. Okay, let's see. We have that, and this is actually already prepared. It is constant for every disease. So you don't need to care about this. Just remember that for the positive likelihood ratio, I use from 1 to 1000. Okay. For negative likelihood ratio, I use from 1 to 0.001. Okay. Why? Because positive likelihood ratio are higher, negative likelihood ratio are lower than 1. Okay, 1 means nothing. Remember, like it's really similar to the relative risk. 1 means nothing. Doing the test or not doing the test is exactly the same. And if you take here, it is the pre-test probability. If you take anything and match it to the 1, it will give you the same result. Okay, so this is how they are distributed. The right scale is just inversed from the first one, and the one is in the middle. Okay, now in here I have a probability of 25%. Okay, and I received a positive test, and this positive test is it does have a likelihood ratio of 10. Then my probability increase to be more than 80%. Okay, I have the same number. Okay, my suspicion in that disease is just 20%. Okay, and I ordered the test, and the result is negative. Okay, so the probability will decrease to be 2%. Okay, so this is the same test. Okay, the same test, and I'm starting from the same point. Getting a positive result takes me to 80%, and having a negative result takes me to 2%. Do you agree this test is truly beneficial?
It is.
It is. Okay. Okay, if I have 2 tests, okay, and I want to think about a positive result, I want to confirm the disease. Okay, I shouldn't compare. I do not care about the negative results. Okay, I think that the result will be 80% positive. So I will compare those 2 tests in the positive likelihood ratio. One has a 100, one has a 10. Okay, so if I start from the same probability, one will take me to 70, one will take me to more than 97%. Okay, so also that test might be really bad in the negative likelihood ratio, but I don't care. Okay, is that clear to you?
Yes.
Yeah, I'm really sorry, but I need to move on.
Get it
Yeah.
actually.
Yeah, Massa, can you just give your answer to just 2 slides later?
Yeah.
And in 3 minutes.
Okay. Remember, in here we start from probability and we end with probability, and don't think that the number in here, just if it is multiplied to the number in here, it will give you the exactly number in here. Okay, just like 2 multiplied by 10 doesn't give you the right number. So those are not calculation. If it is a calculation, I would say don't just draw that scale, just think about it. 2 multiplied by 10. But it's not like this. Why? Because a probability is different from odds. And this scale actually works for odds. So the likelihood ratio multiplied by the odds pre-test will give you the odds post-test, okay? And the odds will be taken from the probability, okay? And probability will be taken to the odds. If I want an exact number, if I don't want to use this scale, what should I do is I take the probability. The first probability I have from a criteria, from my clinical perspective, from whatever it is. I put the probability in here. I calculate the odds. This will be the pre-test odds. I put it in here. Multiply by the likelihood ratio, the negative or the positive one, and take the post-test odds. I put the post-test odds in here and take the post-test probability, or I just relax and take that scale. Okay? And there is actually something that is easier. A likelihood ratio doesn't increase or doesn't decrease the probability by anything. But if I have a likelihood ratio of 2, it will increase by 15%. Okay, those are approximate. Okay, for accurate numbers, those. Okay, for more accurate numbers, take those. For less accurate numbers, think about a test with a likelihood ratio of 10. We will have an increased probability of 45%. For a likelihood ratio that is 0.1, I have a decreased probability of 45%. And actually, a good test is a test that has a likelihood ratio positive more than 10 and a likelihood negative less than 0.1. Okay, I'm really sorry I can't take your questions right now, but maybe in the next call. And I'm truly sorry I'm it's taking so much, but I hope we are doing fine. So see you in 10 minutes or 15.
See you.
Okay.
Okay, I'm preparing myself.
In here we have a pre-test probability. Pre-test probability from 1 per 1,000 to 99%. 99%, I'm quite sure. Okay. Then we have the likelihood ratio, negative just below and positive above 1. Okay, positive are higher than 1, negative are lower than 1. I take let's say I take the 99 probability, pre-test probability, and I get a very low likelihood ratio, a negative test with a very low likelihood ratio. I end up with a probability of 1%. Can you imagine that? With just one test, I reduced the probability from 99% to 1%. Or the other way, I took a test with 0.0 or let's say 1%. I have just 1% suspicion in that patient he will have that disease. And I received a negative test with a very low negative value. I will end up less than 0. The probability will be less than 0. Okay? Just take the pre-test probability, match it to the next to the likelihood ratio, and go in a straight line. It's important to go in a straight line. Don't cheat. To the post-test probability. Okay.
Okay,
Okay,
got it in
now
here.
we go to
This is everything about it?
yeah, this is everything
Ah.
about it, but just remember, a positive tests, positive likelihood ratio high. Negative test, negative high, small likelihood ratio lower. Okay, and so on. And if you compare the line,
Okay, and the
this
third,
line is worse
the
than a line that reaches a high probability. It's better to go to the extremes. Okay, to go to the 99% or to the 0%. Okay, this is the best lines.
okay, and the fourth section.
Column. Yeah, the first column, I have
Why
two lines because I have two tests, okay? The first test has a positive output, and the second test has a positive output, but they are not similar, okay? They are different tests, so they have different likelihood ratio. So one takes me to 70% probability, and the other one takes me to another probability. Okay?
Okay, thank you. Okay,
Yeah, I'm so sorry. I am running. I think we will take more questions at the end of the session, but now we will need to do some data cleaning. The wholly first column, if you remember, the first column is like magic, okay? I can link it to the names, link it to every column in my Excel sheet. So it is really a holy column. I'm sorry, my WhatsApp, there are still some messages. I hope. Just go.
It's nothing.
Okay. No, I was just going to close it, to close the window. Okay. The sorting deadly sins. Okay. Let me go to Excel sheets, and please remember the confidentiality of data. Can you see my screen?
Yes.
Okay, perfect. Okay, in here, what do we have? We have here some columns. It's nothing important. It's all in German. Okay, and when I received it, that was a totally difficult table. Just imagine that I was thinking about those cells, and when I went to here, I found a huge cell, and here we have a huge cell. So this mistake in here shouldn't happen. Okay, we have one column, one information. Okay, we shouldn't have a column with two headings. Okay, just put all the headings you want in one column. Okay, you can't have a huge title CT, and under CT you have different things. No, put CT thickening, for example, CT large, CT high drops, CT whatever it is. Okay, in each cell, but don't put huge cells. Those will go away and will confuse you. Those cells should be divided, should go into the different columns, and if it is no, then we should put no, 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 no to all relevant cells. Okay? Here, let's go here. Okay? We go and we tell Excel, sorry, to do sorting. Okay, I will sort it from A to Z. The sorting tool is truly important. Okay, it will be your hand and leg. But this is the most important thing. Okay, if I use this, say goodbye to your Excel sheet. Okay, say goodbye. Why? Because it will sort that column and it will mix the observations. Why? Because it will put that column is no, yes, while the other columns are saying
Still
the
the
same.
same.
Okay, so the patients are not moving, but their data are moving. Okay, so when you do this, you start your research from the scratch. Okay, don't do it, believe me. Okay, and remember, if you just do it by mistake, you need to have like restoring versions, backup plans. Okay, because you might do it by mistake, and if you do it just once, forget everything about that and go back and do it again. Okay, look, there are some merged cells and I can do it. Okay, so this is a totally important issue. Okay, what do you think about this line? I like this line. Okay, look at it, it looks amazing, especially in German, but what is wrong in it? There is something wrong.
It's like I have numbers and words and everything.
I have a complete report of a CT, I think, okay, in just one cell, and that makes no sense. Okay, how should I deal with it? I should divide it. And how do I divide that? Okay, I divide it like this. Okay, for example, those are for a different column, but I put them, I classify them. I say if I have that embolism, I will put 1. If I don't have it, I'll put 0. And this is a perfect column. Okay, it's not perfect because why? Because what is 0 for all? Okay, he meant 0, 0, 0, 0, but this shouldn't be here. Okay, this should be just a 0, 1, blah blah. Okay, it shouldn't be like this, it should be 1. Okay, those are the types of columns I should deal with: zeros and ones. Okay, or yes and no's. Okay, and remember that if you put a no with a space afterwards, it will be classified differently from a no without space. Okay, so be quite accurate in your data entry, and the best way to do it is through forms, Google Forms and Access forms. Okay, those lines means nothing to me. Those lines here, think about this. I have different units for different patients. Would you like that? And huge cells inside. That shouldn't be the case. Okay, just put the number, one number, and if you have a different unit, just convert the unit and then enter your number. Okay. If you have a column for example, presentation delay, okay, it shouldn't be like one patient is 1 year, the second one is 1 month, the third one is 10 years. Okay, why? Because the 1 month shouldn't be there, or we say like less than a year, or the other option is we divide the year. Instead of a year, we say 12 months. Okay, 12, 1. Then 10 years, 120 months. Okay. So, is that okay? Are you satisfied with? Can you appreciate the difficulty in here?
Yes.
Another. Okay. Let's take this date of last discharge. It seems that some of them have different has like multiple admissions, so for those we have another discharge. But if we take this, for example, mortality, it should just be false and true, false and true. You shouldn't find any other answer. For here, ICU discharge, okay, then in that column, okay, don't just look at the title. because the title might not represent the column. When I name that title, I know what it represents to me, okay? But it can't represent anything to somebody else. So in here, I meant the reason for discharge: death, to whom, to where, what is happening, okay? And if you like, well, we have three options: to the department, home, directly from the ICU, to home, that sometimes happen, and death, which is the most frequent for neural injuries. Okay, length of stay. You can't see any unit in here, okay? Can you see that? 0 for those who didn't enter the ICU. I could have put two columns, one column for entering the ICU or not, and not, okay? Or I put the length of stay in the ICU, and for those who didn't enter, I put 0, 0, 0, 0, okay? How do I put 0, 0, 0, 0? I put the, not the default value to be 0, okay? Can you think about any difficulties in classifying data? This is one of the problems. If you remember, I told you don't put two things in one column, okay? And in that column, I did that. Here we have a spine CT, head CT, head CT, and spine CT. And when I order them, look at that. When I sort them, they will be classified all alone, okay? Then I will have those head, spine, and spine MRI, okay? Skull X-ray. I don't need those to be classified all alone because they are included in the head CT, okay? So this is a problem. This was my mistake, and I paid the price for that. Okay, you look at those columns; those are the perfect columns for SPSS. But you see, there is something in here. Okay, what is that? Okay, actually, when I want to start the analysis, the first thing I should do, I go to each one of those columns. I take this, for example. Actually, I don't take samples of columns. I go to each one of them, and you should do that, each and every column. When I go to that column, I sort smallest to largest, expand the selection, sort 0, 3. Here I don't have anything. Okay, I go to that patient. I know that patient. If there is any, if there are any contact information, for example, for those cells, I actually put the name of the data collector, because those data collectors or collaborators usually know their patients more than I do, because I don't go to, I'm not going to remember every patient and their data collaborators. They will know their patients because each one of them will just collect 50 patients or so. I will ask him, can you fill in this cell? If he says I can fill it, I will, or I will go to the paper questionnaire and I will fill it for you. That would be perfect. If not, we will go and contact the person with the disease, and he will answer us. Okay.
Okay, just a question.
Yeah, please.
Why to go back to the form and fill it again? Why not just fill it in here?
We don't go back to the form. I can fill it in here, but I need the information.
Okay. Yeah, okay.
The information is in the paper form.
Yeah.
Okay, because he just slept or did something while entering that patient, and he didn't enter that value. And we can solve this by making all the columns or all the questions in the questionnaire like required. That would be tough because for some questions, I don't need to enter anything. Because, for example, if that person didn't enter ICU, the next question, how long did he stay there, means nothing. So in that option, I can make it required, but I put an option that is not applicable or something like this. That will be more work, but it will remind you not to forget anything, because sometimes I do not have a paper. Sometimes I enter them into Access directly. Sometimes I just meet the patient and enter them on my tablet. Okay, so if it is required, it will remind me. Loss of consciousness. Here I have categorical data, not just dichotomous data. And I believe for those columns, those were scales, and I think we can calculate means for them, medians, whatever it is. Okay, because those were, if you remember, continuous data, not continuous data, interval data, and we can calculate this stuff for them. Interval. So what did I do? Okay. So for here, I will sort them to. Okay. No loss of consciousness.
If I didn't, excuse me. Can I ask a question?
Yeah, of course.
If I didn't manage to get contact with the patient, or the collector didn't remember the data of the patient, I like, this is, it keeps like a missing value.
Yeah, it stays as a missing value, and you report that in your manuscript. You say that some of our patients lost a follow-up for some outcomes. I lost the values for these outcomes. Okay.
Okay.
Okay. In here we have categorical data. No LOR, loss of consciousness. I don't remember what these numbers were. And here we have a brief loss of consciousness or amnesia. Okay, here we have continuous data. Here we have a lot of numbers. Glasgow Coma Scale, I will sort them, for example, to view who were the worst, who were the best in that value. Okay, sometimes I have missing values, and I know that Glasgow Coma Scale is truly important for neural injuries. So I will go back and I will make sure to meet the doctor who treated them, and I will get the data for that. Okay. Okay. For example, one of the most important mistakes. Those data collaborators, when they were working on this, imagine they put a 0 in here, and that was a totally miserable answer. Why would a person get a 0 value for a Glasgow Coma Scale? He can't be 0. So in here, you can appreciate that, but if you take just the mean and you don't sort them and look into details, they will contribute and they will take your mean lower while they are actually false. And to tell you the truth, and what is actually like a joke, one of them has a Glasgow Coma Scale of 15. Okay, so of course, if he just did the mistake and entered 1, I won't see the sorry, if he, for example, entered 5, I won't see that, and I won't appreciate the mistake. But now I have my opportunity to see some mistakes, like 0 for Glasgow Coma Scale. That is truly difficult. Okay, so don't save. This is the sorting deadly sin. Okay, just one sorting without expanding the selection means like discarding the table. Versions are truly important because I remember one time I saved a new version on my desktop and I kept working on it. And one time I went to go back and I did my edit on another version. And now I have two files with different versions, and I have some new updates in that file and some new updates in that file, and I don't remember anything. The solution is to remember, to list and remember all the edits I did and go back to the original file and do them, okay? So please don't go into that hell as I did. Empty cells, okay? Empty cells should be filled in if we can. If we can't, we should just clarify those are empty cells. For example, let's go into that was, yeah, for the curriculum. Okay, let's go in here. Okay, those are Likert scales. Okay, those are numbers that go from 0 to 4. Okay, I sort them. Okay, what are those cells? I don't know. Okay, actually there are, actually in that file, I put some classifications and some sorting below the data. And this is actually a mistake. I should have entered them in a separate sheet, but I knew that this project was truly small, so I could do them on the same screen, but don't do that. Because when you use the file for educational purposes, it will just fail you. Okay, let's go into this. Sort. Okay, I won't sort this. Okay, here I don't have any answer. Okay, and this is about voluntary work. Okay, I don't know if that person didn't answer this question or this person didn't work in any humanitarian agency or didn't take any voluntary work. Okay, so empty cells in these situations are like difficult to interpret.
Confusing.
Right? Exactly, confusing. Why? Because here I have yes and no, yes and no, yes and no, and an empty cell. Is it unclear? The person doesn't want to answer. Of course, every person has the opportunity, has the free choice to answer or not answer any of my questions. I'm not obligating anybody. So not answering is an answer, but not filling this into that cell is not an answer, and this is confusing. Okay. Do you have questions of blah, field of blah, field of blah, and so on? Okay, I shouldn't put that huge cell field, and under it I put all the fields, and I shouldn't enter like the field of a sentence. Okay, just put one word that represents that column. Okay, field of work. Okay, and I put like a definition into my notebook here on another sheet or something like this to understand what does this word stands for. Okay, because when I'm working on here or when I'm converting them into SPSS, that would be difficult to have a big title for that line. Okay, so and here we should look, for example, sometimes into these numbers, I find a letter. That will make the total column go uninterpreted or unanalyzed because of that letter. So don't do that mistake and just keep watching and investigating every column you might have. Okay, here we have the development of the disease, the prognosis of the disease after 6 months. Okay, so I have different outcomes. تقدم المرض, تراجع المرض. Okay, what is the difference between them? Okay, sometimes, okay, because we have different data collaborators, some of them will interpret تقدم المرض to be like having a bad prognosis, or the disease developed, or تقدم المرض, he thought that the person improved. Okay, the person improved or the disease developed, and those are totally the opposite terms. Okay, so sometimes it's not clear, and this is one of the reasons why we should sit with data collaborators, understand them, because, and when we collect the name of the data collaborator, for example, I couldn't think about this mistake when they were collecting the data. Okay, but after when I was analyzing, I realized, okay, I'm confused. I don't remember what that meant to me when I developed the questionnaire. So I went to them, and I sent a question to them. What do you think تقدم المرض is? Okay, improving or developing, or bad prognosis, or what? Okay, if they all answered the same question, the same answer, I will analyze the same way. Okay, but if they answer differently, I will go to their names, and those, for example, who were filled by data collaborator 1 will be inversed. Okay, and I put these codes instead of long sentences. مدة العلاج أقصر من 6 أشهر. So I don't have an answer here. This is the meaning of no answer. Okay, because there is no 6 months to really think about.
Instead of leaving it empty, isn't it better?
Because we had the stability, okay, not improving or developing the disease, we had the stability. So stability should be 0. What should no 6 months mean? Okay, that shouldn't be analyzed. So for this outcome, I will just select a subgroup of my patients, and I will say those patients have assessment after 6 months, and for those I will do that test. For others, I don't have 6 months, and I won't do that test. Okay.
So I'm not putting a number because I'm excluding them from the
Exactly.
Okay.
Exactly. Here we have a scale, and for a scale, it's difficult. Why? Because if you remember, for a scale, we put the scale, the complete scale, into the questionnaire. We collect the data, and after that, I don't want the data collaborator to just keep confused and thinking about the number they should put for each point of this questionnaire, and scales might be like 20, 30, 40 points. So I don't want them to do that. Excel can do it more efficiently. What I do is I put the questions, they put the answers. Okay, what do I do after that? I go into Excel and I use, yeah, just give me one second. Okay, I go and convert them exactly. I go and use those formulas. For those formulas, I don't have the time to tell you about all the formulas, but if W2, this cell, is yes, give me 1. If not, give me 0, and I will integrate them. Why do I need 1s and 0s for some time, for some scales? Because I will merge them. Okay, that person will have the mean of all of those. And what is even more difficult is when I have a positive and negative questions. For example, for that question, if he has a no, he loses a point, and if he has a yes, he gets a point. What can be more confusing is some of the questions are different from other questions. So some of the questions are positive, they get a point for a yes, and some of the questions get a point for a negative result, for a no. So in here, I can do it, but when I just give that work to a data collaborator and make him think about this, that will be truly difficult, and he will think about it like, and he will do a lot of mistakes. Okay, Excel can do them more efficiently. I tell them for this column give no a 1, and for this column give yes a 1. Okay, and then we take the mean, and after that we can sum them up, take the mean, do whatever we want to do. Okay, those are some of the tips in here. And here, what do we have? Okay, those are truly big. So I think
We have 3 minutes.
that's it for Excel files. Just give me one second. Okay, shouldn't just in the wrong. Okay, now I'm down for your questions. I'm truly sorry for the long presentation. Yeah. Do you need my screen anymore? Yeah. Please, Massa, Sara, anybody, you can also.
I was telling you that we have 3 minutes, nothing else.
Yeah, of course. Yeah, thank you. Massa, you had a question, or yeah, you were answering my question, right?
Yeah, I was answering your question that we convert them, but I have another question. So the main difference between Excel and SPSS that we on Excel we work directly on the same page, but we never convert the data. We just add it. We just add the like.
Massa,
the new data we give
really important. For access, we use it to. I don't know what happened in my.
Not access.
laptop.
I mean
Yeah,
Excel
for,
and
yeah.
SPSS.
Yeah,
Not
just,
access.
okay. Excel and SPSS. Actually, we can do all the work on both of them, but the same work will be more difficult in SPSS. SPSS will give you more advanced options, but that will be tough to play around with SPSS. So keep it for the hard work that can't be done by Excel, and everything else that can be done by Excel, keep it to Excel. Okay?
Okay.
Yeah, I'm really sorry. I can't take any other question because the session will end. And see you next meeting. Please send any questions you might have to the chat, to the WhatsApp group, and see you again in 2 days. Goodbye.